good morning, everyone. Thanks for joining us this morning. I'm Jim Curtin, the Chief Business and Government Relations Officer at Acenda Integrated Health, headquartered in Glassboro, New Jersey. Also, the Acenda Institute of Health Innovation, which is proudly sponsoring this very important event this morning. And also the Chief Business and Government Relations Officer for the newly launched first ever Public Health Institute in the state of New Jersey, which we are so excited about and feel so privileged to be able to launch. And quite frankly, comes at a perfect time for this topic this morning, this webinar, Shifting Perspectives, Tackling the Opioid Epidemic as a Public Health Issue. We've convened a panel with decades and decades of experience in public health and probably nearly 100, if not more years in the area of substance use disorder treatment and prevention treatment and now recovery services. And we're here today to talk about looking at this opioid epidemic through a new lens, a lens that we hope will lead to greater impact. And when we're talking about impact, we're talking about saving lives of individuals, families, communities, and in many ways, our country at large. I remember just a few years ago when we talked about the opioid epidemic and we convened national provider associations, typically the providers from the Northeast and then West Pennsylvania and Ohio would show up and discuss this with great concern. But now, when we have provider associations and we have meetings, the entire country is represented. And that's because the opioid epidemic has spread rapidly across our country. We've all seen the CDC data of 107,000 deaths over a 12-month period ending in 2021. And that would come to 12 people an hour dying in our country. And I realize that recently that data has been adjusted downward, but it's still startling numbers. So what is public health? Public health has been defined as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private, communities, and individuals. I think the best definition that I've heard about public health is all of us. It's all of us. We all have a hand in public health. We all have a responsibility to support each other. People often ask, is the opioid epidemic a public health issue? And I would say the opioid epidemic is one of the worst public health disasters affecting the United States today, and it has been for at least the past 20 years. So as I said today, we have tremendous experience, tremendous talent, tremendous compassion, and most importantly, tremendous heart to do something about this in the United States. So I cannot possibly read all of our participants' full bios because that would take 45 minutes of the 1 hour we have here together. So some logistics, each of our speakers will make opening statements of a few short minutes, and after approximately 10:30, we'll switch to a panel discussion where I will pose questions that you, the audience, ask of our panelists, and then we'll wrap it up all in 1 hour. So we've got a lot to do. So I'm going to get started today by first introducing Beth Connolly, who is the Assistant Director of the Office of Public Health for ONDCP, which is the Office of National Drug Control Policy. Beth, a New Jerseyan, former commissioner of the Department of Human Services, and I can tell you, Beth gets it when it comes to the opioid epidemic and the challenges that we face and more action, the serious actions that are needed. So Beth, without any further ado, I'm going to turn it over to you. And by the way, you can see Beth's full bio in the chat room and on the Acenda website, which is available to you also. Good morning, Beth.
Hi, good morning, and thank you, Jim, and thank you to Acenda for inviting me today, and greetings to everybody from the Executive Office of the President. As Jim mentioned, A life is lost every 5 minutes around the clock due to an overdose. And right now, we're in the most dynamic drug supply environment in our nation's history. We're seeing increase in overdoses from synthetic opioids like fentanyl, from meth, and cocaine. And the mandate from President Biden has been very clear. Reduce the number of drug overdose deaths, put quality public health services within reach for people with substance use disorder, and stop the drug trafficking organizations that seek to profit by harming Americans. That's why the president's inaugural national drug control strategy, which can be found on the White House website, is designed first to save lives and make sure people have the services and supports that they need. The president's strategy looks at the two main drivers of the epidemic: untreated addiction and the drug trafficking profits that fuel it. The strategy prioritizes 4 near-term actions that we must take to meet people where they are to reduce overdoses right in this moment. First and most important action we can take to save lives right now is to have naloxone, the opioid overdose reversal medication, in the hands of everyone who needs it, and without fear and without judgment, especially today when 3 out of every 4 overdose deaths involve opioids. Harm reduction interventions like naloxone enable us to work with people who use drugs to build trust and engagement and keep them alive. Second, the president's strategy lays out actions to tackle a long-standing issue: the fact that fewer than 1 in 10 people who need treatment actually access it. Everyone who wants treatment should be able to get it, and that's the goal of the administration. Through the president's strategy, we seek to double treatment admissions for people most at risk of overdose deaths and ensure universal access to medications for opioid use disorder by 2025, because this is evidence-based care and it's the most effective tool that we have. Third, and this really does, people don't often think of public safety, but it really needs to work in conjunction with public health. So third, the strategy focuses on disrupting transnational criminal organizations and their illicit financial networks and supply chains, targeting where it hurts them most, which is in their wallets. And we continue to work with other nations to make it more costly for drug trafficking organizations in every way. Finally, the fourth pillar in the strategy ramps up our work on data and research at a time when the federal government faces large gaps in data collection and analysis related to drug policy. So we know that one of the best predictors of a fatal overdose is a prior non-fatal overdose. But in too many parts of the US, we don't have consistent and timely measures of non-fatal overdoses. This limits our ability to identify emerging trends and act before it's too late. The sooner we can get comprehensive real-time data, the sooner we can use it to drive sound policy decisions. We recognize that science should drive policy as much as possible, and that's why data is really one of our top 4 priorities. And we are working hard to address these 4 areas. So far, these are just a few. The Biden administration has relaxed rules that make it easier for practitioners to prescribe buprenorphine. So the moratorium on mobile medication bans has been lifted. $30 million has been provided to harm reduction services. And the first time ever in a president's State of the Union address, harm reduction was mentioned, along with treatment, recovery, prevention, and harm reduction. We've made it easier for harm reduction agencies and other agencies to acquire naloxone. And last month, we announced $1.5 billion in new funding for all 50 states and tribal communities to address addiction and the opioid epidemic. And this funding requires states, as a condition to draw down the funding, to articulate how they will assess, acquire, and distribute naloxone in their state. And finally, one of many things, we have launched a recovery-ready workplace webpage with resources dedicated specifically to employers, because we know that people in recovery should be supported at work, and we value their part and participation in the workplace. These are just a few examples, and I assure you there are many more to come. And in March, President Biden announced that he's requesting an unprecedented $42.2 billion in the National Drug Control budget. This is a $3.2 billion increase and 75 cents of every dollar of that increase is targeted to public health, investing in prevention, treatment, harm reduction, and recovery support services. So we've made some great progress, and we continue with the urgency that this crisis demands. I want to thank all of you who do all this work and support prevention, harm reduction, treatment, and recovery. I look forward to hearing from our other speakers and taking your questions. And if I could just say a little at the end, if anyone is trying, and I'm not sure if the chat is enabled here in this Zoom session, but the Executive Office of the President does not have access to chat. So if you're trying to send me a message in the chat, I won't see it. But please feel free to send it to Jim and he can pass it on to me. Thank you.
And Beth, thank you for clarifying that. Thank you so much. And just we encourage all participants to submit questions. As I said, the questions you submit, I'll be posing to our panelists in the second half of this event. Thank you, Beth. Thanks so much for those powerful words and really talking about the amazing work coming out of the federal government and the administration there's been so many firsts, in Washington, D.C., so many firsts, and they're really important. And I think that's why we're here today, to make these firsts every day part of our life in tackling this epidemic. So I'm going to introduce the Acenda Integrated Health COO, Melissa Fox. I can tell you this, Melissa has a long history and an accomplished history in public health, and we're so happy and we're so confident to have her leading the way at Acenda in our newly launched Public Health Institute. So thank you, Melissa, and we're going to turn it over to you.
Thank you so much, Jim. And I just want to recognize all of the other esteemed panelists that are here today. I'm really looking forward to this discussion. And, I'm really glad we're continuing to have this discussion, because addressing opioid misuse as a public health issue is critical to making a substantive impact for the communities we serve. Public health, as Jim mentioned earlier, is all about protecting, promoting, and improving health. So addressing this as a public health concern not only helps to appropriately prioritize policy, funding, community partnerships, recovery models, it also helps to reduce any associated stigma, because it allows it to become a health-related discussion versus an issue of criminality or moral failure. It also helps to address disparities related to racially biased perceptions of addiction in Black and Hispanic communities, similar to what we've seen over the years. I do believe we've made progress in this evolution, but there's still a lot of work to be done. So if we're going to effectively view this issue through a public health lens, we kind of need to go back to the basics, I like to say. And by that, I mean, start with the 10 essential public health services as a framework at a local and even state level. This is kind of a slightly different way to think about it. And I think some of these things are being done, even though there's some more work that we can do in this space. So this kind of seems rudimentary, but it's a good start, I believe, for stakeholders to use to assess their public health approach as it relates to this issue. So the other good thing is, if you've ever looked at this, and you can see it on the CDC site, you can see it on a number of other sites, but if you look at it, it centers equity. And that's critical to ensuring that historically marginalized communities don't get left behind. So if you look at these 10 essential public health services, then the first step is to assess and monitor the population's health. And that's really super critical. And this goes to what's already been stated in terms of understanding the trends at a local level, at a state level, because that ties directly into some of the next steps. The second step, of course, is to investigate, diagnose, and address these health hazards and root causes. This is critical, because when we're looking at different populations, different demographics, different geographic locations, there are different reasons that we're seeing some of the disparities that we're seeing, some of the addiction trends that we're seeing. It can be directly related to these rural locations, access to care. It can be related to lack of communication, lack of education, any number of different things. So understanding, investigating, diagnosing, and then addressing those root causes are critical to looking at this through a public health lens. And then to communicate effectively. This is something that I do believe is starting to happen, or has been happening in a very important way. There's some more work perhaps that needs to be done, but even with some of the conversations going on around rainbow fentanyl and the dangers, I do believe that there's some great communications that are occurring at a community level, that are going on within schools, education for parents, et cetera. So continuing to communicate regarding what's being found out, regarding what the data is saying, and involving the community in these solutions, I think is absolutely important. And so that goes to the next point, which is to strengthen, support, and then mobilize communities and partnerships. And I can't overemphasize this enough. The partnership component to addressing this issue as a public health concern is essential, because these are the voices, these are the other stakeholders who will help to inform the solutions, and who can also help to inform some of these options that are being offered to communities and whether, you know, they are successful or not. Including these other voices is important because there's a clinical lens that we can look through that's absolutely important, but there's also just the integration of these services, the acceptance of these services, the access of the services. And sometimes when you hear from the people on the ground and the people who are being affected the most, you get a totally different perspective of what needs to be done. So really making sure that the partnerships and the right providers and the right partners at the table are important. And so the other steps include things like, you know, creating and championing and implementing these policies, plans, and laws, you know, utilizing legal and regulatory actions. That's extremely important. And that's what we've seen over the years, I think, in a very important way. And we just heard, you know, Beth talk about some of the things that the Biden administration are doing, where we're really engaging true policy legislative change to further these solutions that need to occur based on what we hear in the data, based on what we're hearing from the community, and based on what we are understanding needs to be done to change communication, change understanding of what needs to be happening. And then the next step include things like, you know, ensuring equitable access and really truly incorporating this at a ground level into the solution. So, you know, in a very large way, and Jim talked about it earlier, public health is all about, you know, understanding, using the epidemiology of the issue, understanding its sources, understanding the root causes, having the research that helps to inform the communication and also inform how it's being addressed. Where do the recovery centers need to be? How do we have diverse and available staff that is fully informed, fully educated, and fully accessible? Are the policies in place fully supportive of ensuring equity and access to recovery services? So it does require somewhat of a shift, and there's some of this that's being done, but I do believe that we have a lot more opportunity into making sure that there is a significant shift in a holistic way, not just within one segment, not just within the public health professionals realm, but across the board in terms of clinicians, in terms of community stakeholders, everyone who is affected by this issue, to get aligned in terms of a public health concern. The same way that we address COVID, the same way that we address many other public health concerns within our communities, that is the lens through which we need to look at the opioid epidemic, because if we don't, I do believe that this is something we're going to continue to see, and it continues to evolve and shift. Rainbow fentanyl, all of these other issues that have continued to evolve, it looks very different than what it did 10 years ago. So we don't know what is to come, and I'm sure we'll get into a little bit more of that today. So I'm looking forward to the rest of this discussion. I'm looking forward to furthering this conversation and really talking about how we can enact these public health approaches in a way that's sustainable, that's community driven, that's community informed, and that's equitable. Thank you.
And Melissa, thank you for those very profound points, and points excellent made and very much needed. Our next presenter is Mike Santillo, who is the director of John Brooks Recovery Center, a member of Atlantic Healthcare in Southern New Jersey. And I'll say this about Mike, knowing him for probably almost 3 decades now. You're not going to get more of an expert. Mike is not just an expert in treatment, but an expert in harm reduction. And I often use him myself when I need to kind of ponder issues or to talk about things or to be explained the basis of some public health approaches, not public health approaches, harm reduction approaches. So Mike, we're going to turn it over to you, and thank you.
All right. Thank you, Jim, for that nice introduction. And thank you for inviting me to be part of this impressive panel. So I don't know if I can live up to that introduction, but I'll try. There's basically three areas that I'd like to focus on that I think would help us move toward a more comprehensive and effective approach to treating OUD and battling the opioid epidemic. I'm going to run through those quickly, and then I'll spend a little time on each one. So the first is shifting how we provide OUD services from an acute care model focused on the pathology of SUD and OUD and serial episodes of high-intensity brief interventions aimed at biophysical stabilization to a chronic disease management model that integrates primary care, behavioral health, and recovery support services and focuses on building the internal and external assets required to initiate and to sustain long-term recovery. Now, that's a lot. I'm going to go into that in a little bit more detail. Number two, integrating harm reduction strategies into that continuum of care. And then three, providing easy access to medications for opioid use disorder. So first of all, why shift from an acute care model to a chronic disease management model? And I think we know that individuals with SUD, including OUDs, often require multiple courses of treatment to stabilize their condition. On average, it takes 4 to 5 treatment episodes over an 8-year period before a person reaches their first year of sustained recovery. We know that people recovering from SUDs are not fully stabilized until between 4 to 5 years of sustained remission. And this is interesting. It takes 15 years for a person in recovery to reach the same level as a general public in terms of quality, general quality of life indicators, happiness, self-esteem, and psychological distress. 15 years. We also know that people with SUD require sustained social support, and the key word there is sustained social support, to one, disengage from a culture of addiction into an alternative culture of recovery, and to transition from recovery initiation to lifelong recovery maintenance. And that's where we lose a lot of people, is during that transition from recovery initiation to long-term recovery maintenance. We also know that chronic care approaches, including self-management, family support, and integrated services, like I mentioned earlier, primary care, behavioral health, and recovery support services improve recovery outcomes. And we know that integrated and collaborative care have been shown to optimize recovery outcomes and improve cost effectiveness. So if we all agree that SUD, including OUDs, is a chronic relapsing brain disease, why do we still deliver services through an acute care model? And I think we would all like to think that science and evidence-based practices drive the delivery of services, but the reality is that funding and regulatory regulations drive the delivery of services. So how do we make that shift from an acute care model to a chronic disease management model? And my slogan for today, or bumper sticker for today, is reinforce through regulation and incentivize through funding. I think we need to really think or rethink how we fund services and revise regulations to really incentivize engagement, long-term retention, and wellness. And at least on the funding side, I think we have some models. We have prospective payment systems where reimbursement is based on a predetermined payment, regardless of the intensity of the actual service provided. And we have value-based payment models, which, in contrast to more traditional fee-for-service payment models, that are based on the volume of care provided. Value-based payment models reward providers and incentivize providers based on achievement of quality goals, and in some cases, even cost savings. So if we're going to provide this chronic disease management approach, for one, we're going to be engaging individuals who aren't really ready to stop using. We're also going to be providing services to individuals over a much longer period of time, and we know that relapse and continued use will occur. So that means that we are going to have to provide services throughout all of the stages of change. So we talk about pre-contemplation, contemplation, preparation, action and maintenance, and relapse, and that we're going to have to include harm reduction strategies in that approach. So things like anti-craving, anti-relapse medications, our MOUDs, methadone, buprenorphine, naltrexone, overdose prevention education, overdose reversal medications. We talked about naloxone, Narcan, fentanyl testing strips, needle exchange services, and even safe injection sites. And that's something we might want to talk about a little bit during the questions and comments section. I have some ideas about pop-up and maybe even mobile safe injection sites. We need to provide HIV and hepatitis C prevention, education, and treatment. And lastly, we need to promote a philosophy of hope and healing that utilizes people with lived experience of recovery. I'm talking about peers, people with lived experience in both the management of harm reduction and engagement services. So lastly, it's we need to provide easy access to MOUDs, medications for opioid use disorders. And I think right now, one of the biggest barriers that we see is stigma and discrimination within the recovery community and within the treatment community. As a person in long-term recovery with over 33 years, and as a treatment provider with over 30 years, being part of that community, I feel like I have an obligation and the right to be somewhat critical. And there still is a tremendous amount of stigma and discrimination against medication-assisted treatment, especially methadone. So I don't know that there's a whole lot we can do about the recovery community, but if I go back to my slogan or bumper sticker for the day, which is reinforced through regulation and incentivized through funding, I think there is a lot that we can do on the regulatory side, because there are barriers to easy access to MAT. And I think there are things that we can do on the regulatory side to make it easier for providers to provide MAT. But we also have to regulate that it must be a must that if you are providing services to people with OUDs, that you have to either directly or through linkage provide easy access to medication-assisted treatment. And that has to include all three medications, right? Not just one of the three, but all three: methadone, buprenorphine, and naltrexone. And I think there's also ways in which we can incentivize that through funding, because there are some funding barriers that agencies have to attend to as well. So again, reinforce through regulation, incentivize through funding. We need to make sure that every person with an OUD has easy access to medication-assisted treatment. So I think I'll end there. Look forward to the questions and to the comments section.
Thanks very much, Mike. And that's a perfect segue into our next panelist, Nancy Moore, who is the director of the Ocean County, New Jersey Recovery Center and represents the recovery community. And as Mike pointed out, today we know, unlike decades ago, but today we know that the prevention, treatment, and recovery services, albeit separate and distinct core competencies, really have to be integrated together for people to be able to get on a path of solid recovery and then sustain that path. So Nancy, thank you so much for being with us today, and we're going to turn it over to you.
Okay, thank you for having me. You guys are a real tough act to follow. So, Mike was talking about the anti-stigma. I've been sober for 11 years and I still feel that, because I tried to get sober for over 30 years and I finally did it. But I still have people that look at me as a person in recovery when they know I'm in recovery with that look. But I do my part. With my job, I do a lot of community support, community education and outreach. I run a lot of wellness programs, recovery coaching, and we place a lot of people in sober living. And that's what I wanted to point out here. The community norm has been an abstinence-based pathway to recovery, and that is my pathway of recovery. And it's the most widely accessible program out there. And when people leave treatment and begin their journey, this system is still the dominant pathway available. Everybody, goes for that, and harm reduction can walk alongside any pathway, However, I feel there is a lack of education and effort to find effective strategies to integrate the harm reduction into existing structures that have been abstinence based. Here's an example. We place a lot of participants in their sober housing, and a lot of them are drug and alcohol free. They will not take you if you are on MAT or, and that's a real battle. And then these people are homeless after rehab. And also, I'm not saying it shouldn't, how can I say this? I think that the sober houses, they need to be trained more in this area. They really need to be trained more because it shouldn't be mandated like the state wants for people, for houses to have to accept these clients without some type of training. And I find also when people are on MAT also, I've had clients tell me, well, that's a trigger for me because they're nodding out, so it's like this, it's crazy, but we have to meet the community where it is at and bring them to where they are now rather than pitting them up against each other, good guy against bad with the harm reduction and the abstinence. Because as a person in recovery, the people in the program can get their danders up really fast with MAT and harm reduction. But I guess that's about it. I hope I made sense.
Thank you, Nancy. You made perfect sense. Thanks so much. So we're going to now switch to the second half of our event. The panel, the participants are starting to pose questions, and they're coming in the highly charged subject of harm reduction and needle exchange specifically. They're coming in about school-based prevention and examples of prevention efforts that have been effective, and funding, of course. We can't get away from funding. So let me read the first question, and I am going to pose this question to Mike Santillo. How do you combat that stigma and discrimination within the treatment community surrounding medication-assisted treatment? How do you talk to hesitant providers?
Yeah, well, I think it's, it is the science, right? We need to focus on the science. We need to focus on the data that shows that, MAT, or, now we're talking about MOUDs, medications for opioid use disorder, is the gold standard. All the data reinforces that it is the most effective method for treating opioid use disorders, that it has an impact on reducing overdose, putting people at a less risk for overdose. So I think, it's education, constant education. And there has, maybe I was a bit too overly critical. I tend to be sometimes overly critical. I think things have improved considerably. I mean, in the 30 years that I've been in this field, but I still think we have a long way to go. I think in some ways, when it comes to the general community, again, it's education, education, education. But I think when it comes to providers, there's a ethical responsibility, right? If you're providing somebody treatment to somebody with an opioid use disorder and you're not offering an education and providing education around the use of MOUDs, in some ways that's unethical to me, right? Because this is the best evidence-based practice for the treatment of that disorder. So I think, again, regulations and funding have to incentivize and enforce the use of best practices in our delivery of services. I'm even becoming even more concerned. We talked about, or other people talked about, fentanyl. And I think that we're seeing much more potent, because of fentanyl, right? The substances that our clients are using are much more potent, which means there's going to be a greater impact to brain functioning, which means there's going to be probably even more difficult recovery for many people with a substance use disorder. And I think we're starting to see some of that. I don't think there's any definitive answer to that question, but I think we're starting to see that. And I think there's a potential that could create an even more difficult recovery process for people. So, I think that only reinforces that we're going to need to utilize more effectively these medications.
Thank you, Mike. Thank you. Moving on, and Nancy, this next question is for you, and but I'm going to read what the participant wrote because I think it's very nice and you deserve it. It says, "I applaud you, Nancy. It's been years. You're a heroine. Meeting people where they are at is critical. Can you talk a little about the high school recovery program and how Hope Shed Light is providing services to the community?" This segues into questions about prevention and effective examples of prevention, which we're going to follow up with another panelist after this. So please go ahead, Nancy.
Okay, Hope Sheds Light, we order community support. We have a helpline, we have a chat line, a lot of community outreach and online resources. We just teamed up with the Toms River Police Department. We're part of an opioid response team. And whenever there's a overdose in town, the police department calls us and one of us goes out and we talk to the families and offer services and support, and also talk to the person who has overdosed. Getting back to fentanyl, I have to share this. One of the calls I went on, and it was very disturbing to me because I did lose my son to this horrible disease. And I get real emotional when I talk about that. 14-year-old kids overdosing smoking marijuana because it's laced with fentanyl. And if that doesn't make your back, the hair on your back stand up and make people open up their eyes, they really have to. Because sometimes in the communities, people have their heads in the sand, Also, we do have an anti-stigma program. We work with the local college and a lot of the kids in the colleges and are in recovery. And we put on big events with entertainment, a lot of literature. We also have a recovery high school here. We offer GED services for those that decide that the high school in person is no longer their pathway. And we get them involved with the different community supports that we do have. We do offer for everyone family support meetings, which is open to everyone. We have several different events. We'll have a pop-up drive-in. We'll have a barbecue, and it brings the whole community together in recovery. And these are really nice events. We do have youth programs and a lot of recreational events for them. We'll take them bowling and do several other events. And a lot of them do come from the schools and our GED program, our recovery high school. We involve a lot of local businesses in all of our events and programs. We offer a lot of recovery coaching and family coaching also, which is that's a very big thing right now, because you do need that support. I guess you could call it more or less something like a sponsor, right, in the 12-step program.
Well, thank you, Nancy. And the next question is for Melissa. How can community organizations that don't offer treatment and recovery services also be a part of the solution?
Yeah, thank you for that. And you know, as first of all, I just want to share with Nancy, thank you so much for sharing that and your heartbreak. And you know, it's so reflective of what so many families are having to deal with today. So I thank you for sharing that and applaud you for everything that you've done. You know, when we're talking about partnerships, I mean, that we can't overstate how important that is in everything that we're talking about, because so there's the community organizational partnerships, and I want to address that because that's the question. And there are also there's the community stakeholder partnerships, and that sometimes looks different. So, you know, we talk about peers, you know, those folks with lived experiences helping to guide people. And then there's a larger family issue in the community that is able to bring to bear the language, the solutions, the supports, the recommendations as to what can be successful in their communities. And those voices can't be discounted because they're not part of a formal professional network. I think they need to be part of the equation. And sometimes that's hard to include or hard to figure out how to engage because there's not funding attached to this, per what Michael was saying earlier. You know, there's no incentive for them to be involved in a way that's different and innovative, but there's a way that community providers need to see their way into doing that. And in terms of including the community providers, when we're talking about public health and when we're talking about integrated care, you know, sometimes it's easy to fall into what our lane is, and this is what we do well. And so we're going to just try to expand a little bit on what we do and call that integrated care. But it truly is about expanding the tent and having other people at the table who are able to speak to the other stressors, the other you know, aspects of family life, other issues that could be contributing or inhibiting someone from progressing the way that they can and they should and they deserve to in their recovery journey. You know, we talk a lot about the homeless. We talk a lot about people who are battling with trying to stay, you know, sustain their lives, sustain these are mothers and fathers who are helping to take care of others who are working through their recovery. And so they have other supports that they need. And so we can't put blinders on in terms of focusing on the one issue when there are all these other concerns that are real life that need to be addressed as well. And that's where the other providers and other stakeholders come in to help to do that. Now, what that looks like and how funding supports that, and Mike, I love your bumper sticker because that's true. You know, how does the funding support that? Sometimes we do need to look at how we can, you know, advocate, use these community advocates, use the policy, the folks who are able to influence policy, you know, come together and add these voices. Sometimes it means setting aside our professional egos, you know, as providers, and trying to own it all and saying, you know what, this is not a part that we can do. We need to be able to come to the table and give everyone a piece of the pie so that we can sustain our communities in a different way. So I would say it's absolutely critical. It's absolutely critical because this is a whole person, whole families that we're talking about. We need to engage folks who can support them. And then we also need to set aside our professional egos as organizations and be able to expand the tent, go to our policymakers and say, this is the funding that we need. It may not all come to me. It may not all come to Acenda, but it will go to a partner provider. And that's okay because it's going to help to elevate our community and heal everyone, which benefits everyone at the end.
And thanks so much, Melissa. The next question is for Beth Connolly. It says there is a great need for service providers in terms of licensed and qualified clinical staff. There are currently massive workforce issues, which I'm sure you're aware of. Right? How do you envision treatment providers, state and perhaps the federal level, supporting work together to address this need?
Thank you. That's a great question. So one is really increasing the ability for folks to understand about this type of work in the various professions. So we find that there's not a lot of attention paid to this type of work unless folks are going into a very specialized portion of their education. You know, we're talking about nursing, we're talking about physicians, we're talking about social workers, and peers. Building up the peer workforce is critical in this area. So we've been working with HRSA as well as the Department of Labor, in order to strategize on how to bring these types of curriculums into a more basic and introductory portion of education, so that as more folks are exposed to this type of education, they may find it as a part of a career path. It certainly isn't, there's no silver bullet here, and it will take time, but also increasing the peer workforce. SAMHSA is working on peer credentialing recommendations for states, so that states can increase the peer workforce and also have a peer workforce that is appropriately paid and has appropriate career ladders. And so these are a number of ways in which the federal government can work to help to support this. But at the state level, it's also encouraging local universities to foster these types of programs and learning, and to work with the single state agencies through the funding that's drawn down through those agencies to support peer programs and support credentialing and building these career ladders, and in bringing the peers into the workforce.
Thanks. Thank you so much, Beth. Thank you. And we have several significant challenges, but it would be hard to find somebody in our field to argue that workforce development is our largest challenge at this point. So thank you, Beth, for that excellent answer. The next question, Mike, is for you. It says, are there funded harm reduction programs in the South Jersey area? And if so, is this federal funding?
So we have a provider here in Atlantic County, the South Jersey AIDS Alliance, that have, I believe they were the first harm reduction program in the state of New Jersey, and continue to provide really excellent services in the Atlantic County area. I believe, unfortunately, there's only 7 harm reduction programs, and I can only speak to New Jersey. I don't really know what's happening nationally, but we have 21 counties in New Jersey. There's only 7 harm reduction programs in the state of New Jersey. And I don't want to get into the whole political battle that the South Jersey AIDS Alliance has had to deal with local city government around the services that they provide. They have not been supported by local government, but they do an amazing job. We partner with them, and they do fantastic work. And their funding, I believe there is federal funding, and I believe there's also state funding. So I'm kind of guessing on that, but I believe it's kind of braided federal and state funding. But yes, we do have those services. We're fortunate to have those services when we want to see those services continue and to expand. And I think the South Jersey AIDS Alliance does a fantastic job.
Thanks. And Mike, I have to stick with you for just one more minute, because questions are coming in, as I mentioned earlier, about the highly charged subject of harm reduction. I think it's certainly, from my chair, it's not as polarizing as it once was. We're making progress. But to me, harm reduction is so much more than needle exchange or mobile injection. But why do you think that's what garners the talk to us in generally about why you think there's so much stigma related to that, but also other effective harm reduction methods? I know you mentioned the accessibility of MAT, but are there other things?
Yeah, so I think it's controversial. I think that I think in some ways we maybe need to relabel it. Sometimes we need to rebrand, because God, I wish I could remember his name, but I heard somebody say that harm reduction is really health engagement, right? That's what really harm reduction is. It's engaging people. It's the first thing I heard when I came into this field was, we have to meet people where they're at. Well, we don't do a very good job of that. When I say we, I mean treatment providers. The harm reduction folks, they do that every day. They meet people where they're at, and they engage people in health services. I talked about the HIV and hepatitis C prevention, testing, treatment. They provide all kinds of support services for people based on their need, based on where they're at. So I think maybe sometimes we need to rebrand and have people rethink and kind of redefine what those services are. But I've been thinking a lot about safe injection sites, and I brought that up, and I totally get that people don't want a safe injection site in their neighborhood. I totally get that. I mean, if somebody said we're going to build a safe injection site on your street, I'd have a hard time with that. But we know that there's hot spots where people are injecting on the street, right? Where there's hot spots for overdose. There's hot spots for homelessness. How about pop-up or mobile needle exchange, safe injection sites where we go where the need is, right? Not expect people to come to us, but we go where the need is and we meet those people, both philosophically and literally where they're at, and provide those services, engage those services, because we've seen that these safe injection sites can reduce the overdoses, can reduce the needles that are on the street. Like I said, I might not want it in my neighborhood, but if I live in a neighborhood where my kids, my mother, my father, my brother, my sister are walking by and having to deal with people injecting on the street and having to deal with needles on the street, I might not be opposed to having that safe injection site coming in for a temporary period of time, or be a mobile unit that comes in, addresses the issue. And we've also seen positive outcomes in terms of actually engaging people into treatment, and of course also reducing overdose deaths. So I think maybe we need to even rethink how we deliver services, and maybe do more. We're involved in an initiative now with the Division of Mental Health and Addiction Services here in New Jersey through federal funding, where we're going to be providing mobile medications for SUD. And so again, the idea of, not everyone is going to access services in a traditional brick and mortar setting. We need to go where people are at. We know that there are probably more people out there suffering with an OUD or SUD disorder than are getting treatment. So we maybe need to stop thinking that everybody's going to come to us and start bringing services to them. And we can do that through either a kind of a mobile needle exchange or mobile safe injection site, or through these kinds of mobile medication units.
Thank you, Mike. Thanks very much. Thanks for those excellent points. The next question is multiple parts. I'm going to throw it out, and any of the panelists, please jump right in. But it involves prevention. So the question is, can you speak to the essential elements of what an effective prevention program should look like, both in school and out of schools, or in the community? And at what age do you think it's appropriate to begin to kind of deploy that curriculum, or what grade? So it's a two-part question. Does anybody want to take a response?
I'll jump in first. Oh, Beth, do you want to go? So I'll start with, again, we got to go back to the basics here. First of all, in terms of age, I believe that, and this is going to make me sound very, very old, at least that's what my kids tell me when I say this, it makes me sound very old. But kids today they have access to a lot more information. They're able, I don't think that we give them enough credit, that they're able to process this information, not from a wisdom standpoint, maybe they don't totally understand the context fully, long-term impacts, etc. But they are able to process this information and do something with it according to their experience at wherever they are. So I think that also there are kids in different communities who've been exposed to other layers of influence and input that exposes them to a different level of education. So I do believe that it's not a one size fit all. But I think that the data, and we Mike talked a lot about this, and I was sitting over here applauding everything that you're saying, Mike, because it goes right to the heart of what public health is. If the data is showing that these youth are being, more and more exposed to different information related to drug use, related to overdose, then we should be educating them in a way that's age appropriate. And there are ways to do that. there are ways that that can be done. So again, it's not a one size fit all, but it's totally age appropriate information. And in terms of, I think, what should be included, it has to be culturally appropriate. It has to be according to the community. It has to be informed by the community. It cannot be something, should not be something that is dictated from on high, that is in provider speak. And so, it's something that we hear and we understand, and then we give it to them, and then we expect that they're going to consume it, understand it, and apply it the way that we think. It needs to be something that is culturally appropriate, that is appropriate for their communities, and that is community informed. And it's also somewhat timely. It needs to be kind of incorporated into what they're learning, how they're learning, in a way that makes sense for them. So that's what I would say, just in terms of these prevention programs that are in the schools. We just can't. I think one of the most important things is that it has to be community appropriate and community informed.
And thanks so much, Melissa. And yes, we know that a major task of any effective public health approach is mobilizing and organizing community, helping community to organize. And very often, that's where policy will be born, in community, because we need people with lived experience, and we need people who are directly affected by it to help us develop effective solutions. So Beth, I believe you wanted to expand on this a little bit. I'll turn it over to you.
Sure, and I echo exactly what Melissa said. She couldn't have said, I couldn't say it any better. But age appropriateness. I also it sent, when we talked about prevention before, to I think it was posted in your chat. I emailed it over. That we just conducted a series of 3 webinars on prevention with the National Council of Safe and Supportive Learning. It's through the U.S. Department of Education. And they include, things that are age appropriate, but also there's a funding mechanism. So it really speaks to what's out there and what can we use and what can we replicate in our own systems, and then where does this funding come from? And so the link that I sent, that I think was posted in your chat, is it should have a lot of resources that folks can use.
Thanks very much. And I see you're linking to the audience. The link is in the chat for additional resources, and please take advantage of that. Thank you, Beth. And I have to keep you on the spot one more time, because I have one more question for you. It says, how do we handle physicians who do not accept insurance for opiate use treatments, but do take it for all other chronic conditions? And is this even legal? I realize this is a tough question, Beth, but what's your advice?
So, Leah, I can't opine on the legality since I'm not a lawyer, but I can opine on a couple different things. One is that there's, as Mike was talking about stigma before, there's certainly stigma in the provider community. I was speaking at a panel last week, and a physician whom I know, although we were speaking down in Virginia, came up to me and was talking to me about why, this population is not a population you want to have in your waiting room. So we had a spirited discussion, of course. But yes, this is, really based in stigma, and also based on a lack of understanding, which goes back to our education system and how we've educated doctors, and the stigma that's right through the whole system. Is it legal? So I can't say if it is or not, but I can tell you that the Justice Department released guidance that denying people medication as they're entering into a carceral setting is a violation of the ADA. Now, does that translate into a private, patient relationship with a doctor in an office-based setting? The Justice Department didn't opine on that. But I think it's a signal, right, that we're, starting to say, if this is healthcare, treatment for substance disorder is healthcare. It's like care for your diabetes. It's care for, when we talk about integrated care, it's part of health. And so, pressure on the doctor community is really starting to ramp up. The AMA is very supportive of medications for opioid use disorder and bringing them into the office-based setting. So hopefully these tides have changed. And maybe we're starting to push towards, I'm hopeful that we're pushing towards a space where we can start to reduce the stigma and people can receive treatment where they need it, when they need it.
Thanks, Beth. And yes, I'm hopeful too. And I know we agree that there's still a lot of work to do in this country and expanding the cadre of prescribers who can prescribe life-saving MAT. The hour goes quick, as I promised it would. Thank you, Beth Connolly. Thank you, Melissa Fox. Thank you, Mike Santillo. Thank you, Nancy Moore. The Acenda Institute of Health Innovation is proud to support and send this event to you. The event is being recorded. It has been recorded. And, public health is such a paramount issue in our country, and it should have been, forever, in my opinion, but it seems to be coming to the forefront now, and we've got to capitalize on that. So much about what we do is about timing, and the time is right for us to literally pounce on this and begin to save lives, individuals, communities, families. We're all affected by it, and thank you so much for this powerful message. We appreciate it, and everybody have a wonderful and a blessed day. Thank you so much.
All right. Thank you, Jim.
Thank you.